computer. I am now. Thank you, Sarah. So there's going to be some terminologies here. I'm going to talk about now drugs, pretty much what you need to know about drugs. Okay, here we go. Basic information about drugs. Generic names, trade names. Feel like this is pharmacology 101. Drug classification, categories, side effects, pregnancy, dosing, and route. These are things you're going to need to know, especially next semester when you start going to clinicals. And yes, you will be administering medications. Maybe I'm going to be there with you. Maybe it's somebody else, but you're going to need these information before you can administer medications to the patient. Well, we'll get to that. Here's some basic terminologies I'm going to talk about. Contraindications, precautions, interactions, nursing implications. So, this is part 2. Signs of effectiveness, teaching the patient, client. You don't know this yet, but every time you administer a medication, you're going to sound like you know what you're talking about, and you will be instructing the patient on what this medication is for. I remember back in the days when I went to nursing school, this is how we went to clinicals. We had to carry these big books, which was our the drug guides. And now, just sound confident no matter what. Actually, that is a good idea, Alex. Yeah, sound confident. Make it sound like you know what you're talking about. And now this is Jennifer. This is how we look up medicines now. We are at Valley Hospital here, and now you can use the EMR. You can use your phone to look up medications. It's so easy and convenient. And when you get to your clinical setting, your instructor or your nurse preceptor, they're going to show you how to work these computer systems. This is Cerner. And everything you need to know about this drug, whatever drug this is on the computer. No need to bring your, I think you have Nursing Central, you have an app, it's right there on the computer. And all EMR has it, from Meditech to Cerner and everything else. Because one of the golden rules is you need to know everything about this drug before you can safely administer it. And I'll get to that. Generic and trade names. Generic is your, I don't know how else to explain generic name, versus the trade name, which are the brand names of certain medications, from acetaminophen, Midol, Excedrin. You also have ibuprofen, Motrin, Advil. It depends on the hospital you guys will be going to. Most hospitals use generic medications. So if I'm my levothyroxine medication, thyroid medicine, I'm going to give the patient, it might say levothyroxine, but the patient is used to seeing a certain brand, Synthroid. And that's up to you guys how you're going to explain it to her that or him that this medicine is for, it's generic because of the hospital. It's how it's a purchasing thing. It's the same deal though. Maybe not for the Synthroid. I know Synthroid patients are very specific on there. There's a difference between a brand name and generic with the Synthroid. I'm going too far, but I think we're going to talk about that in Pharm 2. Next, drug classifications and drug category. Drug classification. The aim of drug classification is to ensure that you use the drug safely to achieve at utmost benefits. Some drug classifications include anticonvulsants, antidepressants, your antibiotics, cardiovascular agents. These are groups. From there, there's also like a subcategory. They're grouped together because of their similarities. From an example I can think of is metoprolol, which is a anti-hypertensive medication, but it's also in the category of beta blocker. So you'll get to see these. Here's a big one, side effects and adverse effects. When you get to your clinical settings, you got to know the side effects of these medications. Side effects can be harmful or sometimes beneficial. It depends on the medication. One drug is albuterol. It's a breathing medication for asthma, COPD. One side effect of this medication is it causes the heart rate to go up. Most of the time, I don't want that, but sometimes I want that. Maybe my patient's heart rate is 55. I need your heart rate to get a little higher. So I'm going to help you breathe and also increase your heart rate at the same time. So I want that. Adverse effect is something harmful that can happen to your patient because of this medication. Some adverse effect are confusions, hypotension, tachycardia. There's many. And there's also pregnancy category. Before you have this A, B, C, D, E, F, G, all that stuff. We don't use that anymore. And now the FDA, we don't use that anymore. Here's the FDA has a specific risk benefit classification for pregnancy medications. Now, instead of having a generic, do they have this, do they have that? No, it's depending on the medication. In this case, it's phenytoin, which is an anticonvulsant. We're going to monitor lab values. We're going to monitor some vitals. We're going to monitor some signs and symptoms. So there's no more generic form for these medications for a pregnancy. Here's a big one. Action and indication of a medication. Action is how the drug works. Indication is the reason for using this drug. So when you get to your clinical setting, this is how you're going to administer this medication. Mrs. Jones, this is your metoprolol. I'm giving it to you because your blood pressure is high. This is your antibiotic. I'm giving you this vancomycin drug because of your pneumonia or your foot infection, eye infection, whatever it is. I've got to give you the reason I'm giving you this medicine. If I'm giving you a medicine for no reason, I don't need it. They don't need it. So insulin, we should say insulin indication for type 1 diabetes. For insulin, it's going to be specific to your patient. Maybe you just check your patient's blood sugar and it's let's say 201. Mrs. Jones, I'm going to give you 4 units of regular insulin because your blood sugar is 200. Peak. Or Mrs. Jones, this is your 20 units of long-acting insulin. Peak. I'll give you more details on that next semester. Maybe I will be giving it to you. But next, contraindications and precautions. Terms used in which drug should be given with caution or not given at all. Because sometimes some drugs are contraindicated for something. Let's say I have a patient with bleeding issues, coagulation issues. And here I am about to give him a medicine called Plavix, which is a blood thinner. So I can't give that to the patient because it's a contraindicated. But keep in mind, when you get to this stage, there's also many checks that this medication goes through, from the pharmacy to the doctor, to the pharmacy, to the pharmacy tech, to you. You are the final checker of this medication. Next, interactions. This can occur when more than one drug is administered at a time. Sometimes, you probably know this for your over-the-counter medicines, it would tell you, I don't know, say take Tylenol for your headache, but if you're on blood thinner, don't take it. It's contraindicated for it because of interactions. I just made up those two. I don't know if they're really interaction with them, but a lot of the medicines have interactions. It either increases or decreases the efficacy of the medication. One is Coumadin and some antibiotics. I think Coumadin, and also with some heart medications like amiodarone. So in those cases, still, it's going to go through the checks. You are the final checker. Another thing you're going to be doing when you get to the hospital is you're going to be giving IV medications. It could be an IV piggyback, IV bolus, IV pushes, IV stuff. One thing you need to know, especially if you're administering IV with multiple medications, are compatibility. Okay, that means this IV medication A may not be compatible with IV medication B, so I can't mix them together. And this is what happens when you mix two medications that are not compatible together. This is it creates this. This is going to this is what happened. This is the IV tubing itself. So it has this white kind of it's crystallized thing inside the IV. And just imagine with this crystallized medication going in your patient's blood, that can cause problem. It will cause blockage of that vein. The drug will be ineffective. There's going to be some occlusion with the catheter, thrombophlebitis, organ failure, and sometimes death. Nursing implications and considerations. This is another big one, because it's up to you as the nurse to know these things. You're not there yet, but you will. I know it's kind of scary that you have to know these things, these little bitty things with every single medications. You will. And if it's really, really that important, it's going to tell you on the medication screen itself when you're administering it. One example would be aspirin. Take it with food. Okay. What specific vital signs to monitor? There's another one you need to know. With this metoprolol, I keep saying metoprolol because it's a beta blocker. It's a special heart medication. You need to know that. It's going to be on the test, in your future test. It's going to be, you're going to deal with this medication when you're in the hospital. So know this beta blocker. Because with any other blood pressure medicine, before I can administer a blood pressure medicine, I need to know their blood pressure. So if I'm giving Mrs. Jones their blood pressure, let's say this Norvasc, Mrs. Jones, here's your Norvasc blood pressure medicine. And she asks you, oh, okay. What's my blood pressure, Sonny? I don't know. What do you mean you don't know? Now you're giving me this medicine for high blood pressure, and you don't even know if I have high blood pressure? What if her blood pressure was 90/40, and you gave her this medication, this blood pressure medication? We're going to have rapid response in your hands soon. Next. Some medications also require lab values to be monitored. One thing I listed up here is vancomycin. This is a heavy-duty antibiotic. It works, it's effective, but it's nephrotoxic, meaning it is harmful to the kidneys. So when we're administering vancomycin, you're going to see lab values. They need to be within the range. If I give this patient too much vancomycin, then we're going to kill their kidneys. We're going to do harm to their kidneys. If I give it to them too low, that means the medicine is not being effective for this patient. Signs of effectiveness. When you give, especially with the PRN medications, when you give something, let's say nausea medicine, pain medicine, anxiety medicine, it's also expected for you to evaluate the effectiveness of it. If I just had surgery, I'm in excruciating pain, and you gave me 4 milligrams of morphine, you need to come back within 30 minutes to check if it was effective. Because you're checking to see if my pain is gone, and B, maybe you overdosed me on this morphine. So follow-up is needed for these medications. Skip that one. Patient teaching, client teaching. So when I'm administering this when you're administering this medication to the patient, you're telling them, Mrs. Jones, this is your antibiotics. This is your, let's say, this is your blood pressure medicine called metoprolol. It's a beta blocker, and it's going to lower your blood pressure and also your heart rate. Make sure when you're getting up out of bed, do it slowly. I don't want you to pass out because of some fluid shifting. I know that's kind of moderate to high level, especially when I'm talking about blood pressure. But at least if you're with me at the clinical site, when you're administering medication, you will do your patient teaching at the 2nd grade level as a starting point. So I'm going to go with, Mrs. Jones, this is your blood pressure medicine. Okay, that's all what Mrs. Jones need to know about this medicine. Because if you start talking about, I don't know, this is a beta blocker and axon beta receptor cells, that's over her head. She doesn't know, she's not going to understand. But you may have some patients who know, this is your calcium, their Norvasc. This is your metoprolol, blood pressure medicine. Oh, which one is that, honey, Sunny? Is that my beta blocker? Oh, so you know more about these. Then you can give them more. Yes, this is your beta blocker. And the next one I'm going to give you is your ACE inhibitor. Okay. So start at the low level. Next. It just says we are all responsible for it. Pharmacokinetics. I'm not really going to talk about it this semester. We will talk about it in January, though. I don't know if I have Pharm 1 or Pharm 2, but we'll talk about it. Next thing you need to know, especially when we get to the critical care level. Half-life. Time required for half of the drug to be excreted from the body. You have this thing up here, metoprolol. It's a sedative. We like the sedative because I can put my patient to sleep. When I want to wake him up, I will turn this sucker off and they should wake up within the next, I'd say 10 minutes. Okay. It's not a long-term sedation. Okay. It also depends, there's a lot of factors like their kidney function, liver function, how the body excretes these medications. So if everything is working right, they should wake up. Next one is the therapeutic range. I've talked about it, gave you earlier. Certain medications require certain blood tests. It's like this one. This is an anticonvulsive medication. A patient's dilantin levels in the blood should be between 10 to 20. More, just like the antibiotics, more will give them the side effects. Less will be, it's not going to be effective for them. Especially with this medication, it's a anti-seizure medication. Just imagine if your patient is taking this and they're still having seizure. And after the seizure, they're telling you, or the family is telling you, I don't know why, but my mom is still having seizure. We've been taking the seizure medicine for the past few weeks and she still has it. Maybe we need to check the blood levels. Maybe she's not at the therapeutic range yet, which she shouldn't have been discharged. But that's a different story. Next, legal considerations. Yeah, you can kind of go to jail if you don't do your job. That's I don't know how else to say that. Yeah, because when I looked this up, I looked up nurses who went to jail. I'm sure you've probably seen something in the news recently, but I found these three for the past, I think this is recent, within the past year or two. Look at this one. Ex-nurse, of course, she lost her license, sentenced to death for killing 4 patients by injecting them with air. Oh, this is very purposeful. And when you get to your skills lab next semester, they're going to show you how to get rid of the air when you're injecting something, which is because, as you can see, it's vital. Japanese nurse who killed patients to avoid dealing with relatives is spared the death penalty. I think with this one, I forgot what she did to the patients. I forgot. I know this one, the nurse overdosed the patients, the children, and they died. She purposely overdosed the children. So I don't get it. I don't know the mindset of these people. So sometimes you get in your nose. Oh, hey, I'm gonna pretend I didn't see that. So we don't have evidence in the future. So they don't pull this. Alex said in 2021. All right, mistakes happen when you're administering medications, and it's okay. It's not the end of the world as long as you acknowledge it. And when you give the what does air injection do? Just imagine you have blood in your veins. Just imagine having air in your blood, and now it's going to go poop, 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 travel through your veins, and it's going to go to your heart. And now you may have you can get the air embolus into your heart, which can be fatal. So now this mistake in medication administration, it happens and it's okay. Acknowledge it, because one thing that happens especially in the hospital is let's say I gave Mrs. Jones the wrong medication. I'm freaking out. I don't know if Mrs. Jones is going to die. I don't know what's going to happen. So I'm going to notify the chain of commands. There's process and steps that's involved. But the thing is, when you make this mistake, and you tell your charge nurse, your supervisor, the director, CNO, whoever else is involved, and they're going to do an investigation, it's not about pointing fingers that Jorge did it. He screwed up. He should lose his license. Let's take him to jail. No, it's not about that. It's about finding maybe there was something wrong with the process. Maybe the wrong medication was in the wrong bin. Maybe there's so many factors that can go into this. Maybe the pharmacy tech grabbed the wrong medications and put it in the bin. And they're all looking into that. Maybe the pharmacy tech who did it was working on 16 hours a day for the past 6 weeks because they're severely undermanned. Everything will be looked at. So if this happens to you, participate. And it's just keep in mind that it's not about pointing fingers. Oh, I have to tell you this. When was it? Last semester, maybe 2 semesters ago. There was a student nurse. I was at Sunrise. There was a student nurse who administered the wrong medication to the wrong patient unsupervised. If you don't get anything from this, please, when you're administering medication in the hospital, either be with me or with your instructor or with a nurse. Do not administer anything without any supervision, just to make sure everything is okay. Okay. So the student nurse, I know she was sent home, not sure what happened from there. For the record, it was not a Nevada State College student. It was from another school. But still, So don't do that. And because Sunrise, it's kind of tricky because some hospital rooms at Sunrise, they're old school. They have 2 patients in one room, sometimes 4. So I think the nurse answered the phone or something, and the medication was ready, and the student thought, let me just give it. Since you're there, we've already scanned it, everything's ready to go, and gave it to patient A instead of patient B. So don't do that. There's also these 10 rights of medication administration. That's why there's so many checks. Make sure when you're giving a medication, it is the right patient. That's given. The right medication, the right dose, the right time, the right route. That's a big one, on the right route. Because sometimes the doctor will order, give this antibiotic Rocephin pill by mouth. But then, hey, your patient is NPO for whatever reason. Your patient had a stroke and can't swallow. So that right route is shot. So now we need to think of something. I need to call the doctor and say, Dr. Billy, the patient cannot take this orally. Okay, I'll give it to them IV. And then they'll change, the pharmacy will change it from there. The right education, the right documentation, you will do that when you get to your clinical setting. The right to refuse, this is a big one. If the patient does not want to take it, don't give it to them. Especially certain patients have those patients who's been taking certain medications for a very long time, just like the Synthroid example I was giving you. Here's a levothyroxine generic medicine, Mrs. Jones. I don't want that. I've never taken generic. I take the Synthroid brand. Okay, then if she doesn't want it, she doesn't want it. Does the right to, ooh, good question. Does the right to refuse apply to psych patients as well? It depends on the mental status. If they're ANO times 4, alert to person, place, time, situation, they can refuse. If you take away 1, 2, if they're now ANO times 1, maybe 2, they're not coherent anymore. They're confused. Confused patients cannot refuse. I mean, they'll fight you, but they don't have the mental capacity to refuse. I'm not sure, Tiffany, if you're asking about patients in psych facility. I can't speak to that because I don't know how it works in psych world. Yeah, if they're confused, they can't. Let's say I need to give this confused medicine, let's say, I don't know, let's say antibiotic through the mouth, and they're shut their mouth and they don't want to take it. Okay, but they're confused. It's not their fault, they're confused. So now I'm either going to change it to an IV form. I can even change it to a rectal form. Of course, I have to notify the physician. You're just going to tell him, Mrs. Jones doesn't want to take this or can't take this pill. Okay, we're either going to drop an NG tube, which you will learn next semester, do it rectal, IV. There's many routes. There's many. Hold you down with long. That actually happens a lot, Alex. That's why this therapeutic thing kind of works. Sometimes a lot of times it doesn't. So we have therapeutic, we use medications in this case. Now you're talking about a grandma who's holding down this, whom we are holding down because they're confused. Imagine a 250-pound muscle guy who's cracked out and trying to kill everybody. Oh, that is an all hands on deck. And everybody's holding him down with leather restraints. That's fun. That's the fun part of the ICU ED. We'll talk about it next semester. Maybe we'll even see it. So there's when a medication error happens, there's steps that needs to be done. Step 1, assess the patient, make sure they're okay. And step 3, follow the protocol of the hospital. Malpractice. Question is, do we need malpractice insurance? I get asked that a lot. I don't have it. I've never had it. I know some nurses who have it. But if you're working for a facility, you are covered under their malpractice insurance. If you ever have to go to court for whatever reason, the lawyers of the hospital will prepare you to go to court. Okay? But hey, if you want to get the malpractice insurance, I'm not the person to talk to. You can talk to some of the nurses when you get to the hospital, talk to some of the other instructors, and I'll give you more information. How can a nurse avoid liability claims? There's 13 of them. Here's a couple. 3 checks and 10 rights. These are about the medication administration. If you follow the 10 rights of a medication administration, you'll be okay. Accurate dosage and calculation. Well, we've been talking about that for the past few weeks. You got to make sure our calculations are perfect, especially with the pediatric medications. Know and follow institutional policies and procedures, because Sunrise system is different than Spring Valley system. They do things differently. And usually we keep students in the same healthcare system, but sometimes you're maybe with Valley, you've been Valley for the past few semesters, and now you're going to Sunrise. It kind of sucks, but in a way you get to see how the other side does things. We have Valley Health System, UMC, HCA, and St. Dignity Health, 4 different health systems in the Valley. And they all have different ways of doing things. Look up what you don't know. If you don't know, ask somebody. I am not afraid. If I'm working in the ICU, I don't know anything. I'm Joey. What is this? I've never heard of this thing. What are we doing here? Ask. Don't be afraid to ask. There's no such thing as a dumb question. Do not leave medications at the bedside, because you don't know what's going to happen to this medicine. Maybe I'm going to give them this medicine, this old lady, the grandma, this medication. I left it on the counter and at the bedside table, and the doctor decides, oh, stop that medication because it drops their heart rate too much, and we're going to switch it to something else. You leave the bedside for a minute. Next thing you know, grandma takes it. Big issue. So don't do that. If you have to leave, put it in your pocket. Put it in your fanny pack. I think that's coming back. Next, chart document carefully. Yep, you will see that next semester. This one, listen to the patient. If they tell you, I don't know what that is, I've never taken that before, I would take that as a hint that so they've never taken it before. Maybe take a step back. Maybe the doctor prescribed the wrong medication, or maybe if it is a new drug that they're taking, perfect. Now I can tell you everything about it. Next. Double check, triple check when the dose doesn't feel right. If I have a medicine called Plavix, it's a blood thinner, 1 pill, 75 milligrams, and it says, and here I am, I did all my checks, I did all my scanning, and here I am about to give 4 of these Plavix pills. That should call for a timeout. Why am I giving 4 of these? These are typically 1 pill per day. So I'm going to take a step back. reevaluate. Maybe somebody did the math wrong. Maybe somebody put the order in wrong. Come back, reevaluate. Number 9, label any powder you dilute and any IV bag you use. You will see that when you go to your clinicals, some of the IV bags are labeled because we need to know what's in it. When necessary, seek advice from competent professionals. When I'm seeking advice at the bedside, pharmacy is my best friend. Pharmacy Mike has a desk right there in the unit. Mike, what is this thing? How do I do this? And he's the expert. He'll tell me, oh, do that slow, do that fast. That's for this. Make sure you do this. Okay, thanks. Do not administer drugs prepared by other nurse. Yeah, because you don't know what's in it. You don't know, maybe you just don't. Unless it's in a code blue situation. In a code blue situation, everybody's in a room and it's being prepared right there. Maybe the nurse or the pharmacist is preparing it. Keep drug knowledge up to date, which is kind of difficult because it's continuously changing, but you'll be required to do some CEUs when you become nurses. Last one is label syringes after medications are drawn into the syringe. So if I have a syringe here of Dilaudid and a syringe of, I don't know, Dilantin, I need to know which one's which. Ethical principles in drug administrations. Provide respect. HIPAA, HIPAA, HIPAA. Privacy, privacy, privacy. I think it was Desert Springs recently who said, hey, some of the students, I know they're learning, but they're talking too loud in the hallway with the patients, and they could hear the medications, the patient's case. So if we can turn it down a notch. Okay. That's good. Maintain competence in nursing. Autonomy and truthfulness. So it is understood. It's a given. It's known. It's common knowledge that we as nurses, we will do the right thing. Because if I'm pulling out 2 milligrams of Dilaudid in the from the Pyxis, it is understood that I am going to give this Dilaudid to the patients. But sometimes we have nurses, there's this thing called drug diversion. It's when nurses take out medicine from the machine and instead of giving it to the patient, they give it to themselves. This is called the drug diversion, and it's a big deal. I should have looked up how many nurses are in trouble because of this, but it happens. And when it does happen, you don't go to jail. You're going to go to a rehab facility. There's a process, steps that you have to do. I don't think they take your license away yet. But, and also from your end, if you see somebody, let's like that airport thing, see something, say something. If you see something fishy in the hospital, maybe Nurse Margaret grabbed 2 Percocets, gave one to the patient and pocketed one, say something. Because that's the right thing to do. You're not tattletaling, because one thing is, if this patient who is now high on Percocet or Dilaudid or whatever medication it is, and now they're incapable of doing their job. Just imagine this nurse who's high, taking care of patients, high-risk patients. It's just a recipe for disaster. Beneficence and non-maleficence. Nurse should act in the patient's client's or best interest. We must not inflict harm on the patient. We have this thing, the Florence Nightingale Pledge. You can read it. It's something you will do that when do you guys graduate? December, I think, next year. When you're in your pinning, you will be reciting this. This is a 123-year-old pledge, and it's up to date now. We are having a pinning ceremony in December, first week of December. Watch it. It's kind of good to see. I don't know if you guys can come because we are doing it at the RSC because it's a small cohort, but it'll be live on, I don't know, probably Facebook or YouTube. Watch it so you can see. You might even have some friends there who are graduating. Or if your friend's inviting you to come, come. It's a fun night. There's a couple more terminologies. Confidentiality. I talked about this already. Don't HIPAA. That's pretty much it for confidentiality. Justice. We must always try to give a high standard of care. It doesn't matter if they're if something whole, if they're not nice, if they're homeless, if they're demanding, we're still going to provide the care. I'm still going to give you your Dilaudid or antibiotic, just like norm. Fidelity, keep promises made to the patient. If you tell the patient you're coming back in 30 minutes, please come back, because they remember, they know. Oh, Sonny, you told me you were coming back 30 minutes ago. It's now 4 hours. I was waiting for you, and just come back. And that's all I have for this week. I told you no drug calculations this week, lots of terminologies, and pretty much a down payment for your Pharm 1, pharmacology 1 next semester. And there's a homework if you're having, I know I had issues with the homework this time, and I gave it to you, but I think it was June who found it and did it. But this time it's look under the assessments in ATI. And for next week, we are doing a live review of the finals, same room. Come. I'm not sure if I can record it for those of you who cannot come. I don't know if I have the capability of doing that in that classroom. Is the final going to be all drug calculations? Wait, let me ask, will there be other? I think I want to say about 95% drug calculations. I don't remember off the top of my head. I might throw in, because it's done. Maybe there's one, maybe two that's not. Is the final on everything we'll learn this semester? Nope, recent chapters. Recent, but on the other hand, there's a your conversions from pounds to kilograms. That's a gimme. You should have that under your belt. From what is it, mLs to ounces? That's also a gimme. So just know those. With this test, there's going to be a lot of conversions from, if I need to get to, I don't know, let's say mics per kilogram, maybe I need to convert my pounds into kilograms first, then my mLs to, there's going to be a, there's going to be some calculations before you get to the main calculation for the answer. Rounding. I'll get to that on the review, because I will specify on the question itself how far to round. If you want to study dosage over the winter break, does ATI keep those modules open? It should be open. I don't think I turn it off. Anything else? So when we do the review next Wednesday, it'll be informal. There's no format to it. I'm gonna have some questions. You guys figure it out. Bring some paper. We'll do some practice questions. It'll be good. It'll be a good setup. Bring calculators. Actually, you can use your phone. It's not a real test. Same room. That's where we are on the second floor. I don't know the room number. Questions? What else? What else? Keep it coming. No? No? If there's no more questions, I will see you guys on Wednesday. So the final is essentially, yeah, because practice is, if I can be cumulative, essentially cumulative. No, it's not kind of, sort of, but technically yes, but not really, because everything else was kind of designed to add on to it. It's like you got to know how to convert pounds to kilograms before you can solve my problem. So kind of, sort of, but not really. I don't know if that answers that question. I don't see the practice assessment on ATI. What is that? I will see. I'll see the ATI. I don't know why. I'll see. I'll send an email out on where this assessment is. I know it's there. It's probably in a different section or block, June. But I'll send a no, I think we're past the children part. I couldn't get that thing. But I'll send an email out. I'll figure it out now, where it is.
So we don't have to do the nursing care for children, right?
No, I just gave everybody a pass. I think I put 100 for everybody just so it doesn't mess up the rubric for the scoring for the grade.
Okay, thank you.
So if you saw that you got 100 on it, because I just put it on there. I did it earlier this morning.
Cool.
Anything else? I'm ready for the finals. I'm excited. Oh, and also when we do the review next week, it's informal. If you want to bring, have some coffee, have some snacks, have some chips, it's okay. Just, it's an informal thing. We'll have some random questions. That's all I got. Anything else? No questions, no questions. Thank you, thank me. You're welcome, and see you next week.